Hello, and thank you so much for including me in this wonderful lecture series. The topic of today's conversation will be on cancer pain medicine. My name is Dr. Karina Gritsenko. I'm a professor of anesthesiology at Montefiore Medical Center in New York. There is so much to discuss when it comes to cancer pain management, and there are so many different statistics that I may share with you. But for today, I'm going to give you small blurbs on what I think is important and appropriate for this discussion. There are significant populations who are affected by cancer. In the U.S. alone, 8 million Americans have cancer or a history of cancer, and 1 in 5 deaths in the United States and 1 in 10 deaths worldwide are done per day in terms of cancer-related illness. In fact, there is such a high prevalence of cancer-related pain and cancer-related diseases that the WHO has had multiple initiatives discussing statistics and publicity and emphasizing guidelines on the importance of managing cancer pain medicine and to minimize the cause of unnecessary suffering. For the purposes of today's conversation, there's so much to discuss with cancer and cancer-related pain, but I'd like to address with you the history of cancer pain, which initially began with Dr. Kathleen Foley, who was a neurologist at Sloan Kettering Cancer Center in New York. And in the 1970s, she had an observation of the importance in certain trends that were related to patients with cancer. She had numerous surveys and numerous book reports, book chapters that were assessed, and she noted that death was inevitable, but severe suffering was not, and that we must really focus on the days with compassion and end-of-life skilled care being an important fabric. In fact, Dr. Kathleen Foley is considered one of the founders of cancer pain medicine as its own subspecialty. Some of the statistics she noted were that those patients who were specifically had different types of cancer, had different kinds of percentages of pain. So depending on the type of cancer you have, there could also be somewhat of a prediction with the percentage of and severity of pain syndromes associated with cancer. And this was the first time this was being discussed in the late 1970s and early 80s. These are some examples of osteoblastic and osteolytic lesions that were noticed. Here's our sample of a patient with multiple osteoblastic metastases to the pelvis and lumbar vertebrobodies. On the right, you can see a patient with renal cell carcinoma with lytic lesions. And it was noted that patients who had these bony infiltrations would oftentimes have more pain, as opposed to patients who had hematologic spreads, who might have less pain. So what is the pain source, and how can we try to predict the kind of pain that we're going to see with our patient populations? Well, there's importance to appreciate the different kinds of malignancy-related pains. 4 types of subcategories include anatomy, metastatic pains, like we saw in the previous slide, radiation and chemotherapy-induced pain, and surgical-related pain for those patients who are having perioperative surgical acute pain processes. Notice that less than 10% of pain is unrelated to cancer when we're thinking about anatomy, and over 50% of cancer patients have at least more than one source of pain. So while we have these categories, which are clearly noted by the WHO, there are significant ranges in the causes and sources and sometimes multifactorial cancer-related pains. We know that diseases can cause infiltration and bony metastases, as discussed, and treatments can also cause pain, including surgery, radiotherapy, chemotherapy-based pain, and many coexisting conditions that exist with the cancer can also cause other sequelae of pain, from diabetic peripheral neuropathy to postherpetic neuralgia to trauma and stroke. What's also interesting to note is depending on the severity of the cancer and the metastatic burden of the cancer, there can be different causes and different extremes of pain. 36% of patients in a study review with non-metastatic cancer oftentimes reported pain, but up to 59% of patients reported pain with metastatic cancer. And it was also noted that this would be consistent with outpatient pain as well as with inpatient pain. Those patients with severe pain, with severe disability, could still have a significant infiltration into their quality of life, even as outpatient patients. We're going to go through a few small case examples of the kind of patients we should appreciate to include in our treatment pathways. So if a patient with cancer reports back pain, we are aware that less than 1% of back pain in the general population may be related to cancer. But when a cancer patient reports back pain, 98% of known cancer patients who present with back pain have an underlying malignancy at that area. And that could lead to up to 1/3 of patients who develop metastases specifically to the spine. The most common cancers associated with back pain include prostate, breast, thyroid, and lung. In terms of brachial plexopathies, these are often related to metastatic and radiation and surgical issues. And common areas here, associations include Pancoast tumors, thoracic outlet syndrome, lung surgery, breast cancers, lymphoma, and thyroid. Lumbosacral, pelvic, and cancer pain also have an association. About 70% of these patients present specifically with pain, and 98% eventually develop pain. There can also be weakness and sensory issues, and some of the common cancers associated with this kind of presentation include colorectal, uterine, cervical, breast, sarcoma, and lymphoma. Headache, while being a very non-specific finding symptom, it is also associated with brain tumors. So 60% of patients on diagnosis have brain tumors, 50% of those have brain mets. Only 25% of patients have headaches necessarily in the morning, and only 30 to 60% may have weakness or hemiparesis. Those type of cancers would be associated with breast, lung, prostate, and nasopharyngeal. In terms of peripheral neuropathies, it's important to appreciate that there can be mononeuropathies and also symmetric polyneuropathies. A mononeuropathy can typically be associated with any kind of nerve compression, radicular or intercostal entrapments, but symmetric polyneuropathy can be considered with paraneoplastic syndromes or chemotherapy because they're more global. In terms of post-chemo and radiation, we also know that pain can be associated with both abdominal and pelvic pain in specific cancers, or generalized immunocompromises, including mucositis or acute and postherpetic neuralgia syndromes, which could be secondary sequelae to bone marrow transplant or stem cell transplantation. Of course, we have to include post-surgical in our discussion as well. So if there's a surgery, there's the opportunity to have acute post-operative pain, and of course, acute on chronic pain for those patients who have had other sources of pain and a more significant acute on chronic pain reaction. Some examples can include mastectomies, neck dissection, thoracotomies, and amputation. Now, when we think about all of these sources of pain, it's very important to classify the pain so we can be the best not only diagnosticians, but then treatment physicians. There are typically two categories of pain that we consider: nociceptive and non-nociceptive pain. And while nociceptive can be split into somatic and visceral, and non-nociceptive can be split into sympathetic and neuropathic, you can also consider that there are mixed syndromes as well. One of the most important things to appreciate between nociceptive and non-nociceptive pain is that non-nociceptive pain is harder to diagnose because it can have non-cancer pain on top of it, but also that they're less responsive to opioids. And so while there is an appropriate thought process that we should provide opiates to cancer pain management patients, it is important to understand that non-nociceptive pain patients are less responsive to opioids. Nociceptive pain arises from stimulation of specific pain receptors, which can respond to heat, cold, vibration, stretch, and chemical stimulation released by damaged cells. These are the common syndromes that can respond to opiate relief. There are somatic and visceral distributions of those that can be defined, as opposed to non-nociceptive pain, which arise most typically from peripheral and central nervous systems without specific receptors. And the pain is specifically generated by the nerve cell dysfunction. So most typically, these kind of pain syndromes respond to neuropathic pain agents, less opiate relief from opiate agents. When we think about non-nociceptive pain, we're thinking about neuropathic and sympathetic type pains, both from the CNS and PNS, or from an overactive nervous system. And of course, in addition to neuropathic pain and non-neuropathic pain, we must think about psychologic pain as well, because a large portion of patients' disturbances may include depression, adverse effects of opioids, fear of dying, and suicidality in some cases. It's important to appreciate the multifactorial pathways of pain as a whole, and to appreciate social factors, psychological factors, spiritual factors, mental status, and other cancer-related treatments, including fatigue, anorexia, cachexia, and nausea. There are many different pathways, including hospice-specific pathways for the treatment of cancer pain. And the fact that this is so prevalent in the literature and has grown from the 1970s to present day imply that this should be ingrained as a core foundational aspect of cancer pain management. When we assess patients, it's also to appreciate that there are a number of different clinical pain pathways and assessment pathways, including NRS scores, visual analog scores, pain McGill questionnaires, etc. But it can be very challenging to appreciate how to gauge the pain level of a pain patient. This is an example of the FACES score and some of the secondary outcomes related to sedation that we monitor. This is an example of the McGill Pain Questionnaire. And it's also important to appreciate that as of the 1990s, that there was a statement made by the National Cancer Institute specifically discussing that every patient with cancer should have the expectation of pain control as an integral aspect of his or her care throughout the course of the disease. And in 1990, this was quite pivotal and quite revolutionary. Up until the 1990s, there had been really no long-acting opioid agents. There had been an expectation that if a cancer patient had pain, that they would live in pain. And there was also an appreciation in the 1990s that there were many groups of people, including minorities, women, and the elderly, who were not receiving adequate amounts of analgesic care. So all of this is at the pivotal point where pain management was adjusted for many populations, but especially the cancer pain patient. If we think about this time period, in 1996, there was a revolution in terms of determining the WHO ladder. So the World Health Organization put forth a 3-step ladder for the selection of drugs specifically targeted to cancer patients. By organizing the treatment of how medications were provided, this actually affected morbidity and mortality of patients as well. It was noted that mild pain would be treated with non-opiates and adjuvant pain medicine. Mild pain or moderate pain would be adding an opioid, usually a weak opioid initially. And at the higher levels of pain, moderate to severe, the more potent opiates could be used. And for intractable pain, invasive therapy could also be considered. It was amazing because it was noted that out of the 70 to 100% of patients who use the guidelines, they found this to be an effective means of cancer analgesic care. And this was both helpful for 90% of cancer patients and 75% of terminally ill patients, which allowed for providing a more graceful end-of-life care and death. And over 70% of patients, it was noted, can be treated with simple analgesics and adjuvants. So just by organizing how medications are provided, one can affect both the morbidity and the mortality of actual patients. So with that, significant new guidelines came out. This was something that was noted to be globally visualized. This was something that was able to really catch the wind and spread the fire in an appropriate way. What was also important to appreciate is that while non-cancer pain might have a reduction very easily after a burst of pain, in cancer, there are often typically spikes, at least 4 or 5 spikes above and beyond the breakthrough basal pain, which we call breakthrough pain. And so it became very important to find the appropriate slippery slope for how to treat severe chronic cancer pain appropriately and adequately. Initially, if we model the pain regimen paradigm over the course of the WHO ladder, you can see here the escalation in the same way of steps 1, 2, and 3, with mild, moderate to severe opioid escalation, and then other outside techniques such as neuromodulation. But the more modern approach is actually a concurrent pathway that exists throughout the course of the disease. And nowadays, in this modern society, in addition to medication management and physical therapy and conservative management, and of course concurrent CBT and spiritual therapy, there are many interventional options that also exist, including neuromodulation and neurodestruction and various ablative procedures concurrently with medication management. It's important also simultaneously, I will emphasize this again, appreciate the psychological burden that is placed both on the patient and the family, and why, in addition to the medications and the interventional tools we have at our disposal, to be so respectful of the psychological component of patients' journey through their cancer pain process. In addition to that, just as we do prehabilitation for orthopedic joint replacement surgery, the concept of both prehabilitation, rehabilitation, and continued therapy, physical therapy, occupational therapy, exercise, etc., need to be part of the package of the course of the disease of cancer. There are certainly various physical modalities, including thermal therapy, electrical stimulation, and acupuncture, which have had literature that is documented with improvement. And of course, there are a number of different medications that we consider. I briefly touched on the idea of non-opioids, weak opioids, strong opioids, and neuropathic agents. Some of them are listed in this slide. And of course, there is an emphasis and understanding that for every tool that we give, for every medication that we give, there's also potential risk for everything we do. And Jean Stover, who was one of the original panel members of the National Coalition for Cancer Survivorship, once said in 1991-92, "My dream is for a medication that can both provide the pain while leaving me alert and without side effects." And really, this is where we get into the good, the bad, and the ugly of fighting with the typical side effects of which we are aware with the happy patient. So the benefit of analgesia without the risk of comorbidity. It's a multimodal approach. It's important to consider the risks, the benefits, and the alternatives of both pain suffering, pain perception, and pain behaviors as we give all of these treatments concurrently. We appreciate, and I've mentioned briefly, that there are a myriad of interventional techniques which can be useful, from trigger points to cryoablation to sympathetic blocks to intrathecal pumps to spinal cord stimulation with the cancer pain patient. Certainly, there are many surgeries that can be done both for palliative care as well as for surgical treatment. We understand that there is a large multidisciplinary approach that are put together in a package. And then briefly, in the last 2 minutes that we have for this time together, I'd like to at least mention the importance of palliative care and hospice care. So the concept of palliative care does not mean a sentence to death, but rather a partnership with the patient to respect patient goals, preferences, and choices, and the comprehensive care of the patient, and really paying attention to the patient's moral code and desires and addressing the needs of both the patients as well as the family and the caregivers. Hospice is a philosophy, a place. It could be a place of home care, could be a place of care in the hospital setting, but really is meant to reduce the suffering by controlling the symptoms, consolidating medications, and supporting the patient and family fully, living the best life that they can have until death. Medicare referral to hospice care services in the U.S. have a life expectancy of those patients who are typically less than 6 months if the disease runs its normal course. For hospice, otherwise palliative care can be a prolonged beyond 6-month course of treatment. And really, it's important to appreciate a graceful death and the dying, a support of the symptoms of support during the dying process, and also the symptoms of support of the bereavement for the family afterwards. So while we all recognize that cancer can have a higher morbidity and mortality than the general populations, there is a very special support system that must be put into place to allow for the graceful life and then the graceful death of a patient. With that, I leave you the concept of physical comfort, continued oneself, maintaining relationships for the doctor, the patient, and the family, allowing for the best control for the patient's care, and confronting and preparing for the reflection of their lives. And with that, I leave you, and thank you for giving me the opportunity to talk a little bit about cancer, cancer pain, hospice, and palliative care. And I look forward to any additional questions you may have. Thank you for your time.
Hello, thank you very much, Dr. Karina, for joining us in this symposium. And it's a great pleasure to have you here.
Thank you.
So I have a question for you. and it's about the patients that we have so much problems with them, that the ones that have addiction to crack, addiction to cocaine, addiction to a lot of things, that have cancer and have pain, and we have a lot of problem to deal with these patients. Do you have a protocol for dealing with these patients?
You know, the worlds of addiction medicine and oncologic cancer pain can overlap. And I have had that problem myself. I've had patients where I was asked to call in a prescription and I found out that there were 4 prescriptions at 4 different pharmacies. So it would not be something that I am not familiar with. In terms of protocols, it's very challenging because it's not just sometimes an addiction problem in cancer pain. Sometimes people lose their jobs and they're selling the medication because they need to pay their rent. So there's other factors to take into account, and I've had many stories. So I think that you still have to treat everybody the same way. If there's a concern for iatrogenic behaviors of any kind, urine testing, periodic testing every month. We see anybody who is on an opioid has to have testing, and randomized testing. It's part of their opioid agreement. It's not a contract, it's an opioid agreement. And so maintaining that dialogue with patients, there was this study with Mark Lima actually many years ago, and he actually talked about his own practice in Rochester and how he would bring patients in and roll the dice so that there was no bias, and say, if you have an even number, at the next visit, I'm going to test you. Or no, initially at that visit, I'm going to test you for your urine. If it was an odd number, he would not. And then he escalated the study and said, let me make it easier for you so you can be prepared. If it's an even number, I'm going to test you at the next visit, or odd number. And it didn't necessarily change people's behaviors, even with the forewarning, because addiction is a real problem. So I think maintaining that dialogue with your patients, if you have the right rapport, if you're taking on that relationship and the opioids, and you do the best that you can as a parent, as a physician, as a police officer in this process. And if they break the rules, they break the rules, and you still have to be consistent with your practice.
Yeah.
Not a perfect answer, but maintaining the relationship, appropriate testing, and good conversations are all part of that process.
We don't have this tests here in our hospital, and me and Thiago, we work in a cancer hospital here in the University of São Paulo, and we have many patients with this disease, but unfortunately, it's the same. We have to have conversations and relationships, but sometimes it's very, very challenging. Because,
I mean, they say 1 milligram of oxycodone is $1. So if you're doing 20 milligrams and many tablets, that's somebody's rent, that's somebody's food. They lost their job, they're cachectic, they can't work, very sad stories sometimes. And then some people are just depressed and have bad behavior. So there's a whole range of reasons, and I guess we just do our best.
Yeah.
Another question, please. About the discharge the medications. Do you have a protocol for this or no, or not?
From the hospital, you mean?
For in home, to discharge the patient discharging the medications that not used.
We do 1 month prescriptions if they're controlled substances. If they're not controlled substances and I can give them many refills, I'm very happy to do that because it's easier for them, right? In this presentation, we didn't even talk so much about methadone or intrathecal pumps or all these other complicated things that are possible. I kept it very simple and bread and butter. But the most important thing is if there's a controlled substance, that they'll be followed every month.
Okay.
Thank you very much for your lecture. It was amazing. We do have a question here from Marcio Matsumoto. So he's asking you, should the early performance of interventional procedures before the presence of intense pain be encouraged? And
Yes,
how can we
you don't
convince
even
the
have to ask me that. Yes.
And how can we convince the patient of this necessity when they are evaluating risk versus benefit?
I never convince anybody. I just tell them the risks, the benefits, and the alternatives, and I tell them why I'm right. But or I hope, I don't know, no. But you go with the patient's comfort. Some people are afraid of pills, and some people are afraid of needles. And if it's a celiac plexus block for somebody with pancreatic cancer, of course, I would want to do something like that if it mitigates their medication load, their side effect profile. If I can do some kind of intercostal cryoablation, for somebody who has metastatic rib fractures. We didn't get into any of that in this presentation, but there's so much opportunity that has been developed over the years. And, the old way of thinking about the WHO ladder was step 1, 2, 3, and number 4, somewhere over there is going to be interventional procedures. But now, we do accept that it's just part of the milieu of our multimodal management.
Okay, that's really interesting. So I will ask like a last question for you. Actually, I'm curious because we know that ketamine is a really interesting drug.
I love ketamine.
Yeah, also for neuropathic pain.
Yeah.
So I'd like to hear from you nowadays, what are your use with ketamine? Only for neuropathic pain or for maybe depression or another thing that can help you? Well, how do you use neuropathic pain?
So how do you
use ketamine?
I'm going to keep us on time, and I could give a whole lecture on this topic. And I just did one for Harvard actually a few months ago. So there's pros and cons to ketamine. The summary is it's an amazing multimodal use nociceptive neuropathic drug. You have to know how to use it and when to use it. It can be useful in acute pain and chronic pain. And I think it's an amazing tool in our toolbox that's underutilized. Sometimes infusions can be complicated because of insurance and coverage and financial factors, but it's a wonderful tool that I definitely think has a place in this area.
Yeah, that's perfect. So I think we are almost done. So I'd like to thank you for joining us here. It was an amazing lecture. We hope that we can see you in person next time. Right?
Yes, I'm
ready. You as well. So I do appreciate your time.
And obrigada for the invitation. That's all I can say. But thank you so much.
Perfect.
Very much,
Doctor. Very much.
Bye-bye.
Bye.
Bye-bye.